So it's not very comforting when somebody is asked or somebody's come to you for the gold standard treatment for obstructive sleep apnea for a child. You have done the best you can and there are problems. So that's what we're going to talk about in the next 10-15 minutes. So all the pictures and videos that I'm going to show here have been consented for. If you look at in India, 9.6% of school-going kids have sleep apnea. 9.6%. And if you take away the children with comorbidities, this is the normal, regular school-going kids. So what is the gold standard therapy? Which is TNA for children and CPAP for adults. So you have done the TNA. But you are landed up with what is now called as persistent OSA. So what is persistent OSA by definition? By definition, and if you were to do the sleep study, if there is an AHI, and in kids you have to use something called as OAHI. Because in kids, CAHI is also very common. Because in adults, obstructive sleep apnea is very common. In kids, is almost equal. Because when you talk about syndromic kids, there may be central apneas as well. So by definition, if there is 1.5 events per hour on polysomnography after adenotonsillectomy, then it's called persistent OSA. Now, persistent OSA is not synonymous with syndromic kids. There are a lot of normal, regular children that look normal who may have persistent OSA. So, if you look at the guidelines and you do this kind of so you've done the tonsillectomy. So much space, right? Should be good, right? Kids should do well. And you've done all the adenoidectomies and you've done all the tonsils. And so, if you bring all the success rates together, Dr. Joby was showing success rates for about 30%. But there's never a number, right? It's always a wide range. It's all over the room. 27% to 80%. So how do you know the child in front of you is in that 80% or 27%? And this is a child very similar to what Dr. Joby was showing, post-adenotonsillectomy, pre-teen, having persistent increased work of breathing. And this is the sleep study on watchpad, 34 to 5. How many people think this is normal? How many of you think this is normal? Not normal, because in pediatric, 1 is significant, right? So there is significant amount of residual OSA. So it's up to us to really get to the bottom of this, because you can't, like in an adult, say, okay, I tried my best, try and get a CPAP. You cannot. Because the adherence for CPAP in children is 20%. The maximum they can use is 2 hours. This boy, regular child, right? Regular looking child, adenotonsillectomy done. This is my case. Pre-op 17 AHI, post-op 11. Not good. Severe OSA. Can you imagine somebody who looks like this lands up still with severe OSA post-adenotonsillectomy? So there are 15 to 33% of patients have persistent symptoms in spite of adenotonsillectomy. So what are we missing here? So we need to understand, we need to take one step back and see that the human body is actually designed to adapt. not to heal. Alright? So if you are thrown in Antarctica, you will adapt. Like this very nice plant. If you put it to the side, it will bend and grow towards the sunlight. But it will not just die. It will bend. But what has happened in all this bending? There's something called as stress. Stress for these kids starting right from high cortisol in amniotic fluid, maternal OSA, OSA in pregnancy which is now huge, insufficient breastfeeding, ultra-processed food, modern homes which are sensory deprivation chambers. Our kids, they walk on carpeted floors, they wear slippers, they talk to Alexa and put the fan on and the AC on. They don't go get up and do everything. Non-verbal communication most of the time. I see my kids. Where are you? Where is this? They don't talk. They're on the phone or they're watching TV. And environmental stress. All of this are huge burdens on children. So, I bring to you what is called as allostatic load. So, what is allostatic load? Allostatic load is actually the sum of all these pressures on us. So what happens is, once they are subjected to all this, once there is so much of load on this, body obviously has to survive. What does it do? Does it heal those? It can't. So it adapts. And in these adaptations are two major problems which the dentists call as form and function. So these adaptations that are happening as a consequence of allostatic load is resulting in bad posture because of head, hip and spine. Because if you have to breathe because of huge adenoids or a persistent nose block, you have to extend the neck. And then if you extend the neck, you can't walk like this. If you can't walk like this, you have to bring the head forward. If you bring the head forward, the chest has to go inside. If the chest has to go inside, the pelvis has to come in front. So each one of them are a domino effect of one single thing. Now what does that result in? Can you breathe better like this or breathe better like this? Obviously. So that affects breathing and that affects respiration. As Dr. Joby was speaking about diaphragmatic breathing. Can you do diaphragmatic breathing like this? No, you can't. So what is happening? You are becoming asymmetrical. So there are two trees here. Both are standing. Correct? But one is a symmetric tree, one is an asymmetric tree. Now, who will stand once there is a storm? The chances that this will stand once there is a hail and wind is more than this one. But right now they are both standing, right? So if you look at somebody who's asymmetric and you think that let them fall, then we will see, that is a wrong concept. They are already asymmetric. If we identify that asymmetry based on what we are seeing, if we pick up these asymmetric children before, then there is a higher chance that they don't fall. Because you are not bothered about this symmetrical guy. He won't fall. The slightest of the wind will topple this tree. Okay? So that is the concept that we need to understand. And with this understanding, if you look at OSA in children,
Check.
this guy is back.
Check.
So, if you look at OSA in kids, the symptoms of school-going kids is very different from symptoms of OSA for a toddler, is very different from an infant, very different from a preschool. They all don't come with same symptoms. So if you don't ask those questions because you don't know, for example, in an infant, disturbed sleep, repetitive crying, noisy breathing, nocturnal sweating, poor suckling reflex. These are the things, failure to thread, that is in infant. Whereas in a school-going kid, regular heavy snoring, mouth breathing, sleepwalking, night terrors, ADHD-like symptoms, poor eating and growth problems. Now what are the common symptoms? They are both sleep-related breathing disorder but different manifestations. So with age, everything changes. So this is a puzzle, right? So how do you bring these puzzles together and how do you start? And this is something that I have learned from the dentist. It's very important that you look at the child right from the moment they enter into your clinic. Now, because of what I spoke, the moment the child is sitting in front of you, you know what is wrong with this child. The moment you're looking at this child, you know what's going on. And of course, needless to say, what is going on. So if we were to do just an adenotonsillectomy in these guys, will we succeed? The obvious adenotonsils, the obvious TRMRs that I spoke about, these things need to be seen. What has happened in ENT is that we've become ultra-luminal. We have become, with our fancy scopes, we just go in and just look into. Dr. Saud was showing this morning about the ALR. I think you were showing, somebody else was talking about, Sanu was talking about that. Davis, sorry man. Somebody was talking about that. And of course, the epidemic nowadays that we see, these kids. If you just, do you know the success rate of adenotonsillectomy in an obese child? 46 to 50% only. That means there is a higher chance that you will succeed with heads and tails if you toss a coin than you will succeed with an adenotonsillectomy in an obese child. Just imagine. So there are a number of significant kids out there following adenotonsillectomy floating around. And you can't put them on CPAP. So this is something that I want to bring your attention to. This is a list of all the facts. I brought a lot of studies together and made this chart. If you look at the causes of obstruction post-adenotonsillectomy, where are all the obstructions happening? Yes, definitely nose. Nose means jaw. What he's speaking about as nasomaxillary complex. Okay, there is significant, about 70% is there. But look where else it's happening. 66%, 72%, tongue base and epiglottis. There is obstruction out there. So how will we know tongue base and epiglottis for every child? Do we know? We don't do scopies for all our children with adenotonsillectomy. So, when do you call it significant? This is also very important. If by definition there is an adenotonsillectomy and there are actual apneas that are happening, and if you do a sleep study more than one, then you call it persistent OSA. But if the AHI is between 1 to 5, you can possibly get away with INCS and LTRA. LTRA means leukotriene receptor antagonist. But with a caveat. The caveat with using montelukast is because it now comes with a black box warning that if you give it in children who have behavioral problems, their problems get worse and get complex with suicidal thoughts. So AHI more than 5 requires immediate active interaction. This is not virgin cases. These are post-TNA. So, in a case, you would like to do a sleep study, but you may not get that access. For example, in Hyderabad, there are only 2 centers that do pediatric sleep apnea studies. Why is that important? Because you need to measure ETCO2. Cutaneous ETCO2 monitoring is required to score pediatric sleep apnea. You can't just do an adult probe and say that, but it's difficult. So what do? So the most important thing is, if you have a child who's more than 2 years old with syndrome, try and get a sleep study done. If you are forced to do an adenotonsillectomy on a child below 2 years, also get a sleep study done. Why? Because you may be missing central events. Now, it's very important that we get these questionnaires done. Why do we need to get questionnaires done? Because you as a clinician, you have done your part and you evaluated. But ours is a very complex society. Ours is a Google-driven ChatGPT society. We don't know what is coming from the parent's mind, right? The thought process. So I always get a PSQ and a OSA 18 questionnaire, not in all kids. If the parent is asking more questions, please get this done. Because it is important that you and the parent are on the same page. Now, when are you forced to do a sleep assessment before TNA? Do any of them look abnormal to you? Okay, this guy's got Prader-Willi syndrome. This guy is called Lawrence-Moulbedel syndrome. This guy is just obese. This child has got Alexander syndrome. They all look normal. So it's again very important to ask and delve into history as to you may think you are, because we are not pediatricians, right? We are ENT. But the patient is with us. So if we do not put the right step forward, the chance of you counseling the patient pre-op will matter. This is a child of Crouzons. I always play this because adenotonsillectomy done. Oh, you're not seeing that. So actually it is Strider. Okay? Patient, here is the importance of having videos. If you would have heard the video, if the doctor would have asked for the video, and he would have seen the video, he would have never missed it. So the parent came with history of breathing. Parent said snoring. He looked in, saw grade 3, grade 4 tonsils, adenoids, and he went and removed it. Post-surgery, patient symptom is the same. So the patient again came back saying, sir, my child is still snoring. So I said, get a video. So, is there? No, it's here. It's okay, man. So it's again important to get the videos. So why is identifying these kids very important? Because these kids with persistent OSA have cardiovascular effects, hypertension, right heart failure, pulmonary hypertension, ventricular remodeling, neurocognitive problems, behavioral consequences, persistent enuresis or what is called a secondary enuresis, and somatic growth retardation. Now, if so much is happening under the hood, we need to find out. And this is a paper that says that persistent oxygen deprivation to the brain causes cortical atrophy. So the child who is growing, because of persistent hypoxia, there is cortical atrophy as well. So there will be learning disabilities. And of course, needless to say, of what is happening under the nose. So this brings us to a very important time in this talk. And I think I'll need all of your intervention in this. So what happens when the palate goes up and it's hitting the skull base, the septum gets deviated, obviously. So what is the classical teaching of septoplasty? Do not touch it till 16 to 18 years of age. But the problem is, if you wait for that long, the form and function will both get affected. So what is the best practice? This is published in Laryngoscope. It says that pediatric septoplasty may be safely performed without significantly affecting future nasal and facial growth. Septoplasty should not be deterred until adolescence. But will you go ahead and just take a scissors and take off the entire septum? No. You will. All of us are doing endoscopic septoplasties nowadays. You are conservative. We are going to not touch the growth centers. Right? So, how can we predict failures in our patients? If there is a history and if the child has been having features of apnea in the video, you can actually do a HSCRP even before, and we've done a study and it's waiting to be published. We've done 30 cases and we've seen resolution of HSCRP after adenotonsillectomy in these kids. So you can actually use HSCRP as a marker of oxidative stress. So what are the factors that can bring your success down? Of course, syndromic children, craniofacial anomalies, obesity, allergy. So once it is a persistent OSA, please remember it is a multi-level disease and please involve other sort of contributors to this disease. Now it's not a one-man show. It has to be a multi-starrer movie. It cannot run on one person's, it cannot be a single, you need a team. So, can we try conservative? Yes, if you have an obese child. So I've told you, OSA is prevalent in up to 60% in obese children. And each unit increase in BMI raises the risk of OSA by 12%. So, obese children have a higher prevalence of adenotonsillectomy hypertrophy. I'm sure all of you have seen this. Obese kids have big tonsils. Why? Because of the endocrine factors that play a role. Because all the organs become big for them. It's just not the adenoids and tonsils. Generally, obese kids are also big kids. Right? And weight loss should be important in their planning in addition to doing adenotonsillectomy. What about Montelukast? When you have that window of opportunity to treat the patient for 3 to 4 months, then only start conservative management. So who are these kids? Kids who have that much amount of time, that is the mild kids. Like I said in the beginning, there is no neurocognitive problem happening yet. So you can try this. Like I spoke about CPAP, the mean usage is only 2 hours. So what about the current literature? No RCT, PAP versus no PAP. There are no literature on quantity or quality of life. There is concerns on long-term growth, done. Okay, let me just quickly come and finish off one. So I just want you to know this condition. Okay, it's called sleep-dependent laryngomalacia. The laryngomalacia is not there when the patient is awake. So when you do an FLP in the OP, you will not see it. Again brings the thing that get a sleep video. Right? And in DISE only this will be picked up. So this is called sleep-dependent laryngomalacia. And always you can do supraglottoplasties, pre-op, post-op, you'll get good pictures. This, of course, they have spoken. So, this is the algorithm. What I will do is, I will make this as a PDF and I will send it to Sanu and all of you can get it. Thank you very much. Thanks.
Thank you so much, sir. That was a great information for all of us.